So we're talking about difficult decisions. It's an interesting way to end a conference on a kind of an issue like that, not sending you away with a song in your heart, but sending you away fully aware of the kind of challenges that you face. I'm chairing. I'm also going to say a few things, and then I'm going to introduce our panel. I'm not going to tell you much about them because they're all incredibly well known and because their names are all behind me. I'm going to keep standing throughout the whole of this session in order that I can keep them to their 4 minutes and keep the whole thing pushing along, because it seems to me that the ultimate objective that I have is to finish this session at 1:20 in order that you get your lunch on time. That's the only thing I'm going to be judged for, and I know it. Let me start off by making a few comments before I bring in our esteemed panel to talk about this question of how it is we maintain support when making difficult decisions. So I want to give you 2 examples of how it's possible, and I'm going to give you a theoretical framework, which isn't bad for 4 minutes, a theoretical framework, not just the thing you need before lunch, a theoretical framework. But so the 2 examples of how it's possible. First of all, one that many of you will know, but Patricia Hewitt, in my view, a heroic Secretary of State for Health, before she took on that job, did succeed in driving through a difficult reorganisation in Leicester as a consequence of the fact that she genuinely used a citizens' jury approach which she had developed at the think tank IPPR before she became an MP. Using that approach over a weekend, I think she brought people together, stakeholders, members of the public, invited the local press and the health authorities, spent the weekend discussing the proposal. The outcome was support for the proposal, but with quite significant changes to respond to public and stakeholder concerns. At the end of that, amazingly, the local press dropped their opposition and the thing went through reasonably well. The point about that story, I think, is that you can do these processes, but you can only do them if they're genuine. And I have spent many years in Downing Street advising various prime ministers, other times, trying to persuade politicians to undertake processes like this, and in the end they say only if I can control it. And the reality is, if you want a process that you can control completely, then it isn't a process that's going to work. That's the first one. The second one is Adair Turner. So I think if we had said 10 years ago that a policy package would be pushed through which contained the following components: raising the retirement age, but basically a compulsory savings scheme for workers, low-income and medium-income workers, and a compulsory employer contribution, basically a tax on employers, people would have thought you were barking mad. All of these 3 things, each one of those 3 things was profoundly unpopular. All 3 of them have now happened, with virtually hardly a murmur of dissent. Why is that? I think it's simply because Adair, as a respected figure, spent about 18 months making sure the public absolutely understood that something had to happen. And by the end of that process, the idea we are all living longer and therefore we're going to have to do some stuff was pretty much ingrained, even in the kind of those people with the biggest stake in stirring up public suspicion and antipathy, by which, of course, I mean the Daily Mail. So Adair, what he achieved in that process, nearly over the dead body of Gordon Brown, has to be said, but what he achieved in that process was pretty remarkable. And if there's one reason for it, I think it was because he spent a lot of time making the case that something had to be done. And I think, generally speaking, when we try and make difficult choices, we don't invest enough time in winning over the public to understanding that something has to be done. We get too quickly into the solutions. And then finally, a theoretical framework in 1 minute. So the theoretical framework we use at the RSA is that we argue that social change relies on 3 sources of power, 3 ways in which change happens. Individualism, change driven by competition and markets, acquisitiveness, risk-taking, selfishness, lots of good things, lots of bad things. Change driven by solidarity, shared norms, shared values, the tribe we're part of, social responsibility. And thirdly, change driven by hierarchy, change driven by doing what we're told or what we're telling other people to. Those are the 3 sources of power for all of us in society. They reflect who we are as a species. And it's always quite interesting to look at any problem from the angle of those 3 perspectives. So what I would say, my theoretical framework on how it is you get support in difficult circumstances for difficult decisions, is you need to align all 3 of those. So first of all, hierarchically, you actually have to have a good plan. And you have to have thought it through, and you have to make sure the governance is all right. It's amazing to me how often difficult decisions fail because actually they haven't been sufficiently well planned in the first place, or somebody got the governance wrong, and it's possible actually to launch a successful legal challenge. So first of all, you've absolutely got to know that you've got as far as you know, your plan is as good as it can be, and you've got your ducks in the row in relation to the governance and process. Secondly, in relation to the individualist part, there will be people who will oppose a difficult decision for self-interested reasons. Newspapers, local politicians, other people. They're not opposing the decision because they don't like the decision. They don't care about the decision. They're opposing it because they think they can win votes, sell newspapers, become local celebrities as a consequence. Those people have to be fought. They have to be identified and they have to be fought to the death. How you do it, we can get into, but those people can never be. You can never deal with those people because it's in their interests to have the row, okay? And then thirdly, solidarity, how you mobilise that is through the kind of process I described by Patricia here, which is by engaging those people who do ultimately share your values and aims. They want to achieve the same things as you, but they're not sure about the means. And those are the people you have to be willing to invest time in, to take risks with, to genuinely include them in the process because they're the people who can be won over. And you have to separate out those two groups. Otherwise, you won't succeed. And forever what we do, and then my final line, I've seen this happen 100 times, is we invite into the room both that second group and that third group. We invite the people who share our ends and we could engage with and we could talk to with the people who are going to fight us regardless of what we say because it's in their self-interest to do so. And unfortunately, in those circumstances, it's very difficult to make progress. There's my theoretical framework, my two examples of success. I'm not going to say another word apart from to introduce the panel, and here they all are. They've all got 4 minutes each, and when they speak for more than 5 minutes, I'm going to physically wrestle them back into their chairs. And they are in no particular order. We're going to start with Neil Bacon, Chief Executive and founder of iWantGreatCare Limited. Neil, your 4.5 minute starts now.
Yeah, I'm looking forward to the wrestling in 5.5 minutes. I'd suggest that it's the wrong question. We shouldn't be asking ourselves not how we take the public with us, but how we go with them. I think when we start saying maintaining their support, taking them with us, it's the worst sort of paternalistic, anachronistic term. It suggests we know best, and they're lucky to have us. And we've spent 2 days saying that that's all wrong. We know that patients vote with their feet. We're patients. We know the public do it. It was on the radio again this morning. People moving over from the Welsh border, some of them, into England. Those that know the care is really different. We know now that increasingly people use the internet when they want to find care for their children, when they think about which nursing homes they should put their parents in. And of course, most of us, our children will be making that decision soon. And they will be turning to the internet to check they get a nice cheap nursing care home that will look after us. So the answer to maintaining support is actually do what the public want, listen to the voice of patients, both individuals and their charities, and then the support comes with it because you're doing what people want, you're doing what society wants rather than what you think they should have. And what does society want? I would suggest what patients want, and a lot of the data, we'll all be saying the same thing, is similar for any other service in sector. They want honesty, they want transparency, they want high quality, they want convenience, and increasingly they want information. They want information so that they can be sure the care they're getting, or the care their child's getting, is great care, is high quality. They don't want lies. They don't want the lie, all the NHS is wonderful. They don't want politicians and journalists arguing with each other based on dogma. And they don't want last century's arguments about competition versus choice. That doesn't matter when you're receiving healthcare. As others have said, what people want is to know they're getting high-quality care that doesn't waste money, that is efficient and modern, and as Tim pointed out, when appropriate, that care should be delivered online. They want evidence that the care they're getting is focused on high-quality outputs, evidence, and that empowers the patients. When we do that, as has just been said over and over again this morning, it reduces cost. Give people quality information, they will reduce the costs of healthcare. This is the bit where everybody who's had their prostate examined should look slightly uncomfortable. On Question Time, David Dimbleby always asks for a show of hands, and I've always wanted to do that, and this seems to be as close as I'll ever get to it. So, as many have pointed out, we need to hear the patient voice. The patient... Oh, you should look uncomfortable, Roy. This is when the patient voice is coming real. So everybody who's had their prostate examined, this is your chance to take part, for your voice to be heard. So how many of you... And actually, I don't want to be sexist. If anybody else wants to join in, if you've had a cervical smear, you join in. So how many of you, in the middle of that exam, were thinking, I'm so glad this is being done free at the point of care. I'm really glad that my doctor passionately believes in the future of the NHS as a universal service for all, irrespective of my ability to pay. Let me hazard a guess. Not that many of you. Not even you, Roy, was thinking that at the time. But, given that the King's Fund tells us there are wide variations in performance and gaps in the quality of general practice, and the NAO tells us that 10,000 lives are lost each year due to variation in cancer diagnosis in primary care, what you probably should have been thinking, what I should think, and what all patients should think is this doctor or nurse any good? Am I going to be one of the 10,000 who's missed? And is this practice where I'm registered excellent, average, or bad? I'm sort of guessing none of those thoughts were in your minds either. But the point I'm making with this is that, of course, when MORI survey and say, do you want the NHS to last forever and be free? Of course people say yes. Do you want a wonderful hospital right next door and an A&E? Of course people say yes. But I think the reality is that the consumerisation now of healthcare, the citizens empowered by information, the reality is that people are, as we've just heard with the pensions discussion, they're much more realistic. They want to know they're getting the best care, they want to know it's efficient, and they want to know the way it's been done and the changes that are being made will make sure that the NHS continues for them and for future generations. The way to take people with us when we make difficult decisions is to focus on those issues, what matters to them, what matters to their family, and not dogma. Thank you very much.
Neil. We're going to applaud all the speakers, because that's the kind of mood we're in today. Now, I'd love to have Ben now, because I'd love to have Ben troping straight off the back of Neil saying you should give the public what they want, because as far as I'm concerned, Ben spent his entire life convincing us the public's absolutely no idea what it wants. But, Ben, hold that thought, which I know you'll be sharing with us in just a few minutes, to the end of the session. Ruth Carnall is, have I got that right? Yeah, very good. Strategic Advisor on Health to the Mayor of London. Ruth, share with us how you maintain support for difficult decisions.
OK, well, I agree with Neil on one point. You don't start by trying to get support for a decision that you want to make. So you have to start by having a philosophy of engagement with staff, with the public, with patients, everybody. That has to be the ongoing routine of the way that you do your job, so that you have a relationship before you start down a track that says, and we want to make this phenomenally difficult and controversial change. Second point, don't expect to succeed. Okay, don't expect to succeed when things get difficult in keeping everybody on board, because if that's the presumption you make, then down the track comes the sort of compromise that will result in a poor result actually in the end. So you're better off trying to confront some of the opposition, trying to confront some of the different points of view, than you are in the sort of let's try to keep everybody on board mentality. From my experience, the biggest single thing that makes a contribution to trying to be able to see through difficult change is having an absolutely compelling case for change. What is it that's wrong with what we're doing at the moment? Why is it that what we're doing at the moment is no good? And the language of that case for change for me has to have emotional resonance for people. So it has to be compelling. It has to compel people to take action about something, and it has to condemn them if they don't. And nothing short of that is going to get people out of bed in the morning to make some of the difficult changes that are necessary. Of course it has to have evidence, but it also has to have emotional resonance for people. The consequence of that, of course, is that if people believe it, they will demand that you make whatever changes it is tomorrow morning. And of course, that's very difficult to do. And then that puts managers, clinicians and others in an extraordinarily difficult position. But it's a better position to be in than one where you're trying to secure change on the back of some bureaucratic nonsense set of, entirely balanced arguments. Again, though, no matter how well you do that, in the end, my experience has been there is inherently conflict in some of these difficult choices. There are trade-offs to be made between access, quality and money. And those choices are difficult. No matter how you cut it, they are. And to make them, you have to have authority. And that is unwelcome often. So you say that, it sounds like, something that has to be entirely top-down and therefore is something that is bad. Everybody wants bottom-up. But in reality, you cannot make decisions in that way. You have to make decisions with authority. And on the other hand, when things take forever and we come up with bland compromises, people say, isn't it a shame we haven't got strong leadership around here? Why haven't we got strong leaders who are willing to take decisions and take it on the chin? You can't have both. So, my experience, case for change, absolutely essential. Second, clinical leadership. You cannot make a change unless you can answer the question, where are the 6 doctors who are going to go on the telly and say that this is the right thing to do for patients? And if those 6, 7, 8, however many doctors and nurses aren't there who are going to go on the telly and say why this is the right thing to do and are going to stand up in front of a politician who wants some sort of compromise, then don't bother. Because without clinical leadership, you're not going to get anywhere. But what I would say is the thing we sometimes often fail on, is providing those brave souls with the right sort of support. There are literally hundreds of willing clinicians around who are willing to take all the brickbats that come with this, all the vitriol from their colleagues, from the general public, from politicians, everybody else, willing to do it because they believe the evidence about what good care actually looks like. But if you don't provide them with the support that they need, they're going to disappear off and do the day job, not worry about doing it. And I think we're very poor at doing that. Lastly, effective implementation. Once a decision has been taken, in my experience, the general public then turn around and say, why the hell is it taking you so long to implement this? They might have spent 20 years arguing that it's the wrong thing to do. They want it all done within a short period of time. And I think that's absolutely right. They should demand that it's implemented effectively and quickly. So really gearing up to implementation whilst the argument is going on is very difficult because that's judicial review territory and it has everybody saying, well, you already made your mind up, you already knew what you were going to do. But on balance, I think it's better to gear up implementation capacity while the debate is going on. And last point, evaluation. The stroke changes in London, which are now very popular on every possible front, were hugely opposed. Now, people have forgotten that now because they like the outcome, but they've forgotten that it was actively opposed by everybody from the Secretary of State downwards. And the only reason now that people see that it's good is because we invested a huge amount of money in evaluation and putting that evaluation into the public domain. So as well as good experience of their care, obviously, there's actually concrete evidence about how and why it's worked. And all of a sudden, not only was it a fantastic idea, but rather bizarrely, everybody was responsible for implementing it, which is great, actually, because that is bottom-up, isn't it? Everybody has now taken responsibility for implementing it, which is great. Thank you very much.
Thank you. I sense, Ruth, that we all feel that if you were out in front, we'd all be marching behind you. Now, Roy Lilley, you're known for your vivacious personality, your unnaturally youthful visage. It doesn't look like you've ever had to make a difficult decision in your life.
No.
What, is that it?
I've just flipped a coin and that was it. Because that's probably about the best you can do. Listen, I am the worst person to ask this question to, because I have no idea what the answer is. I closed.
I didn't choose the panel.
But it's a free lunch, and the Tories have closed my day centre, so there's no bingo on Friday. So I'm here. Bastards. Anyway, let's not get political about them. Bastards. Look, I closed a mental health institution and I had my car vandalised and my mother threatened with threatening letters. So, I know how difficult it can be. The question starts with, how do you maintain support? Well, I think first of all, before you can maintain it, you've got to get it. And you can by no means be sure that you can get it. If we look at the drivers for change that are happening at the moment, there are 4 drivers as I see it. There's CCGs. I was at a mental health trust yesterday. Some of you will have read what I wrote this morning. And this trust is going broke. It's a fantastic place. The staff are just working till they drop. But the CCGs are still insisting on a block contract with 14% less money. And they've had 3 months of trying to meet with the commissioners, and the GPs won't turn up. They just won't talk. So that kind of sucks all the energy out of maintaining support for any of the difficult changes. Then if you have a look at the regulators, I mean, the regulators are there to do the government's dirty work. Monitor and the CQC are imposing impossible demands on trusts. And then as a result of them not reaching their benchmarks, they're calling them failing. They're then coming in saying, this is failing, this is dangerous, and in the public interest, we're going to close it, move it, shift it, reorganise it. So, and it's a lie, and you can't have any confidence in that either. So you can't, the way we're doing it, it doesn't maintain any confidence. Then you've got the big trusts. The big trusts amuse me. I mean, it's like they're living in a different world. I picked up a piece of gossip that Bob the Builder at the UCLH had a row with the Flat Earthers, the CQC, over their inspection. And Bob threatened to bring in Mishcons and sue them. So they rewrote the report. Now, I didn't believe that, but I published it anyway because it was a good story. And now I discovered, courtesy the fabulous HSJ, that it's true. And I got another email this morning. They said that you think it was bad at UCLH. They did it at King's as well. So, they're not going to change anything, are they? They're too big to change. And then finally, you've got the kind of domino theory of change where things just fold and you can't get involved with it, like Southern Cross. When they ran out of money, we were all worried we were going to push the grannies up the high street in a wheelchair because there was nowhere else to put them. So all of those 4 areas of change, we've got no control over. It's all out of our hands and it's all very difficult. So where do you go? Well, I mean, I do think that, first of all, I think you have to believe yourself in what you're doing is right. And that's important. I've seen so many NHS managers implementing change and implementing consultational. They didn't believe in it themselves. And you can see they didn't. So you have to believe in it yourself. And I think that's quite important. And secondly, I think you won't take everybody with you. So don't beat yourself up. If you think you're doing the right thing, that's fine. And thirdly, there's a little saying that I've always remembered, and it's people love change if they think they're in charge. And I think involving people, getting them to work with you is important. It's such a cliche. There's nothing new in it. None of us have got anything new to say about this. If you want to change things, you have to take people with you. You won't take everybody with you. Don't beat yourself up. I've just finished chairing the People's Inquiry into Healthcare in London. We publish our report in a couple of weeks' time. And the really overwhelming thing that comes out of the evidence, and I don't want to preempt the report, but is the extent to which people's opinions are actually ignored, how badly consultation is handled. And I don't know why we even bother people with consultation, because we don't give a toss, we're going to do it anyway. So, I am very kind of cynical about the whole thing. And to answer your question, how do you maintain support when difficult decisions are made? First of all, you have to get the support. One of the things that we're recommending in the report, so I'm going to get in trouble for preempting the report, but I think that we need to look more at citizens' juries. I've seen them work at NICE, and I've seen them work in the States, as you have, I think. And they're kind of lumpy around the edges, and yes, they do worry the politicians, but that's what politicians are there for, and you can't expect politicians to do anything other than say whatever it takes to get elected next time round. I mean, you can't trust any of them. So you know, I think that I quite like the citizens' jury thing. So I think the thing is, first of all, you have to believe in it. Secondly, don't beat yourself up if you can't get everybody following you down the high street with rose petals. And thirdly, Ruth is right, get on with it. Because the longer you leave it, the worse it gets and the bigger the damage on your car.
Very good. Thank you, Roy. Do you notice, Roy, how your three things match my three things, actually? About, you know, being clear about what you wanted, bringing on the people you can bring on board, and not worrying about those you can't bring on board.
I think that's very good advice, Matthew.
Very good. Now, I think Julie Birchall once said that common sense is the G-spot of Middle England. Ben Page has been looking for that G-spot and has regularly found it for many, many years. I've been working on that line. Could you tell?
Yeah, it's getting.
I thought I'd end with something slightly more positive than the prostate.
Okay.
Right, Ben, over to you.
Look, thank you very much. I'll talk a bit about a few things. So just in relation to what Neil said, if you offer people, obviously, a perfect free hospital round their corner, yes, strangely, they all quite like the idea. But actually, at the moment, and to some of the things you've been talking about over the last couple of days, we now have in Britain, partly with austerity, a record level of people accepting that the NHS as originally configured was a great idea but cannot go on. Now, it's still only 30%. I don't know if Paul Corrigan's still here because he's always wanted this number to increase. When he was working for Blair, it was about 22%. So, but it is going up quite quickly, and there is acknowledgement that things need to change, but they want reassurance. And in terms of who's going to give that, well, I give it back to you, because I think one of the pieces of work we did a couple of years ago was looking at reconfigurations that went well, and ones where the people in charge basically may as well have bought a 12-bore and slowly shot their toes off one by one because of the way, the cack-handed way they managed to go about alienating virtually everybody, including the people who actually wanted to do it. And a lot of it, one of the people that took part in that was we did about 50 or 60 hour-long interviews with some of the successful players in this. Was about the power of personal leadership. And I know it's all about distributed leadership and your crowd of followers and all of this stuff. But unfortunately, looking at this, it still comes down heavily to people who are willing to really take the lead. And we are talking here about engaging your clinicians. We need not a cigarette paper of difference between them, or we are doomed. Once one of them goes native and starts agreeing with the MP, you have big problems. I think in terms of transparency, there are lots of conspiracy theorists out there, and hiding anything is a real issue. One of the interesting points that came out was make sure there's actually nothing to FOI, because you've put it all online in the first place. So it's all there. There aren't any secrets or things for them to find out about. So overall, if we give you the 10 things that came back from the people who didn't blow their toes off with a 12-bore, they are these 10 things. The first is about personal visibility and being there when you are going to go and talk to the public. I think it's also a fantasy to talk about the public in this context. It is the activists and people who are interested. They are not the public, bless them. The public is something else. It doesn't even exist. We'll talk about that if you want to. Visibility with colleagues. People are going to get tired. They're going to need you. You've got to be there for them as they go through this process, because you aren't, as everybody has just acknowledged, going to get loads of, you will get the blame will be much more visible than the praise, so you're going to have to be there for them. One thing that did stand out was setting very clear standards for consistency and transparency and the criteria that are being used to make that decision, and actually getting group consensus about that with the people and the partners that you're working with. And then we get into the dark arts in the nicest possible way, but this is realpolitik. Target the people who matter. That's the people in the media, the local politicians, and do that before you start the consultation. Have those conversations, get the narrative right. So is the next one, number 5. And here, I think we need to talk about gains before loss. So many people, I love working with the NHS because I know some of my local government colleagues are here, but you're much cleverer than my local government colleagues. If you look at the exam grades of people in the NHS, they're all much higher than in local government. But local government have elections to keep them honest. Whereas the NHS is full of very, very clever people who sometimes, occasionally, very clever people lack emotional intelligence. The other interesting thing is that increasingly, and I don't know if Matthew was referring to this, we're finding that even very, very clever people, when faced with numbers they care about, turn out to become innumerate quite quickly. And one issue here is finding people who genuinely don't have an axe to grind and get them to look at the numbers and talk about it. But getting that narrative right about the gains before the losses. If I was involved in reconfiguring any NHS services in a major area, I would be making sure there were lots of nice buildings with blue flash signs on them, new things coming here before I started to close things. And I know it's expensive running things at the same time, but certainly just that narrative about what the benefits are going to be and getting everybody online on that. An interesting point that some of these people were making about don't dig your heels in. Now, you can say, look, this is the right thing to do. We've got to build the polyclinics or whatever, or take people past the hospital in a longer ambulance journey to the stroke centre. My mother has been saved by Ruth's work, so I'm a big fan of it. But you might want to think about what ground you would give, or be clear that actually if something's coming back, can you change the terrain you're fighting on? Number 7, risk-taking over transparency. It's the point I made at the beginning. Put the stuff out there. It's going to come out eventually anyway. Nothing in this wonderful world that we live in is WikiLeaks, whistleblowers, and all of our friends. And Roy will tell you about the fact that you've hired Mishcons. Get it, make sure it's all there so there's nothing to come out. Look for opportunities for co-creation. So the people who have public reference groups who will stand up and say, I'm not a stooge, I'm not part of this, I've given up my time to do this, and this is why I believe it's the right thing, really important. I love citizens' juries. I think they're fantastic. The only issue with them, I would say, and when you do them, they are still only 12 or 20 people. And if they come out and again, they say, yes, this is what we believe, your friends in the Sun, if you did one on hanging in this country after a major paedophile incident had got a lot of attention, perhaps, you do the citizens' jury and it says, well, we don't really think that hanging people is a good idea, however many children they've murdered. And the Sun will then say, well, who were these liberal sort of types that you got onto this thing? And you paid them 70 quid a day so they could give up work to go and take part in this intensive process. You must be bloody joking. I've just done my poll and asked people to dial in and they all thought it was a great idea, hanging people. So, the jury itself runs into some of the problems that the experts might face. Lots of things about emotional intelligence. And then think, finally, point number 10, about those moments of truth when you're going to be under pressure, you aren't going to give way, and those tipping points when actually opinion does, as Ruth has indicated, shift over. But I think the more we plan for that, because where I've seen people go wrong is where they know that rationally this is what we should do, and therefore we're all clever people, you're all clever people, we won't patronise you, we're just going to do what the clever people say we should do, is where things have gone horribly, horribly wrong. The end, and